This case is an example of teenage pregnancy and consent. A 15-year-old girl presents with her 15-year-old boyfriend requesting termination of pregnancy. Their relationship is consensual, means no one is enforcing the other in this relationship, okay? Both of them has the same age and their relationship is consensual, and they request termination of pregnancy. What is the most appropriate action here? Inform parents, report to authorities, refuse care, refer to a medical abortion service, delay decision. The correct answer is refer to a medical abortion service. Why? In consensual relationships with similar age, confidential reproductive care is appropriate. The appropriate action is confidential. Don't notify the parents and don't notify the authorities. Don't report to the authorities, okay? You need to keep the care confidential. So confidential reproductive care is appropriate, is the most appropriate action here. Mandatory reporting is not required in most Australian jurisdictions. So mandatory reporting is not required in this case. Why the other options are incorrect? Parental notification is not mandatory. You need to keep the care confidential. Reporting is not necessary without abuse. Only reporting to the authorities will be necessary if there is abuse, if there is a child abuse, okay? Both of these partners are of similar age, so there is no child abuse, and their relationship is consensual. Refusal or delay violates the patient autonomy, okay? So refusal to give the appropriate reproductive care or delay the treatment, delay the care of this patient will violate the patient autonomy. The patient autonomy means the patient right to have appropriate care. So the most appropriate next step is to refer to a medical abortion. So you need to know that there are conditions, specific conditions that you should respond to a patient request to terminate the pregnancy. The first one is here. If the patient is requesting. The second one is this one. The second one is this one. Molar pregnancy. Molar pregnancy should be evacuated. The pregnancy should be terminated. Okay. So this patient is a 40-year-old woman with vaginal bleeding and positive pregnancy test. Okay, she's not requesting termination of her pregnancy, but you should terminate the pregnancy here. So all of these are transvaginal ultrasound. Okay, grayscale transverse and longitudinal ultrasound images of the uterus. This is the transverse and longitudinal ultrasound images, transverse and longitudinal ultrasound images of the uterus show a large echogenic lesion with innumerable cystic spaces. A large echogenic lesion a large echogenic lesion with innumerable cystic spaces within, filling up the uterine cavity. These lesions are filling this is the cervical cavity, this is the endocervical cavity, this is the intrauterine cavity. So these lesions are filling up the uterine cavity. No definite myometrial involvement. So these lesions does not extend beyond the myometrium or does not involve the myometrium. They are confined to the endometrial cavity. Echogenic lesions with cystic spaces. Color Doppler image shows mild peripheral vascularity. This is the color Doppler image showing mild peripheral vascularity. This is the peripheral vascularity. In a patient with elevated HCG level, the echogenic uterine lesion with numerous cystic spaces is diagnostic of a molar pregnancy. Lack of demonstrated or demonstrable fetal parts, lack of fetal parts, okay, suggests a complete hydatiform mole. Lack of fetal parts, there is no demonstrated fetal parts here. So this is not partial molar pregnancy, this is complete. All the pregnancy here are molar pregnancy. There is no fetal parts. Absence of myometrial invasion makes an invasive mole or choriocarcinoma less likely. So the absence of myometrial invasion makes invasive molar pregnancy or choriocarcinoma less likely. So the differential diagnosis of molar pregnancy, of complete molar pregnancy, is partial molar pregnancy where there is fetal parts are demonstrated. Invasive, the next differential diagnosis is invasive molar pregnancy or choriocarcinoma where myometrial invasion will be demonstrated. Gestational trophoblastic disease is a spectrum of disorders caused by abnormal proliferation of pregnancy-associated trophoblasts that range from complete and partial hydatiform mole, complete or partial hydatiform mole, to invasive mole, to choriocarcinoma. So these are the types of gestational trophoblastic disease: partial hydatiform mole, complete hydatiform mole, invasive mole, choriocarcinoma. Lesions that invade locally or metastasize are grouped together as gestational trophoblastic neoplasm. A complete hydatiform mole is the most common form of gestational trophoblastic disease. So what is the most common form? Complete hydatiform mole. This case, complete hydatiform mole is the most common cause of gestational trophoblastic disease. Molar pregnancy is common in women aged below 20 and after 35. Okay, that's why the optimum age of pregnancy is between 20 to 35, as below 20 and after 35 there is high risk of molar pregnancy. Fetal parts are absent in complete hydatiform mole. Clinically, molar pregnancy presents with enlarged uterus, vaginal bleeding, rapidly rising HCG levels. Classic ultrasound finding is an echogenic intrauterine lesion, with multiple anechoic cystic spaces, giving the snowstorm or cluster of grapes appearance. Snowstorm or cluster of grapes appearance. Okay, echogenic lesion with multiple cystic spaces, giving the snowstorm or cluster of grapes appearance. Low resistance, increased vascularity is often identified in molar pregnancy. Low resistance of the blood vessel is a characteristic finding in a molar pregnancy. Molar pregnancy is associated with multiple thecal luteal cysts due to ovarian hyperstimulation. So molar pregnancy is associated with multiple theca luteal cysts. Multiple theca luteal cysts is seen in many conditions, including the molar pregnancy, okay, due to ovarian hyperstimulation. So the theca luteal cyst is seen also in ovarian hyperstimulation syndrome, may be seen in twins pregnancy. Elevated HCG levels 6 months after evaluation of a molar pregnancy are concerning for invasive mole or metastatic disease. After evacuation, So after evacuation of molar pregnancy, you need to follow up the lab test for HCG levels. Okay, 6 months after evacuation of the molar pregnancy. If the HCG levels are still elevated, this is concerning for invasive or metastatic disease. This is concerning for invasive. So the evacuated molar tissue, the molar pregnancy is not completely evacuated because there are invasive parts are still present in the myometrium of the uterus, or because there are metastases to other parts of the body. That's why the human chorionic gonadotropin levels are still elevated 6 months after evacuation of the molar pregnancy. Invasive mole extends into the myometrium but do not metastasize. So invasive mole just invade the myometrium. However, choriocarcinoma is commonly to metastasize to the lungs. If you remember, cannonball metastasis is a characteristic finding of choriocarcinoma metastasis to the lungs. So invasive mole commonly invade the myometrium only, but do not metastasize. However, choriocarcinoma metastasize to the lungs. Management, evacuation, dilatation and evacuation. Okay, termination of pregnancy. Okay, so the management here, dilatation and evacuation. Cervical dilatation. Okay, cervical dilatation and evacuation. Chemotherapy, if it is invasive, molar pregnancy. If it is invasive, give chemotherapy. If it is metastatic, if it is choriocarcinoma and metastasized to the lungs, give chemotherapy. So the treatment here is cervical dilatation and evacuation. If it is invasive or metastatic, give adjuvant chemotherapy. Okay. This is another case of hydatiform mole. The figure on the left. The figure on the left is the transvaginal ultrasound of the uterus. What is the classic term used to describe these findings in the endometrium? We mentioned it before, hydatiform. We mentioned it before. This is a snowstorm appearance or the cluster of grapes appearance. Let's see. This is molar pregnancy. This is a snowstorm appearance. Okay. So this is a this is a transvaginal ultrasound of the uterus. And this is the snowstorm appearance. Echogenic lesion is seen in the intrauterine cavity with multiple cystic lesions, giving the snowstorm or cluster of grapes appearance. What pathologic feature is responsible for this appearance? Hydropic placental villi in a complete molar pregnancy. This is complete molar pregnancy. So the pathology here is hydropic placental villi. What laboratory test could help confirm this identity? Laboratory test. Markedly elevated human chorionic gonadotropin levels. This is the laboratory test that will help. What type of ovarian cysts? That we have mentioned before. What type of ovarian cysts are seen with this identity? As you can see here, this is the sagittal view of the right ovary. This is the right ovary. Okay, this is the right ovarian tissue, and as you can see here, there are multiple cystic lesions. These are theca lutein cysts. As I mentioned before here, that molar pregnancy are usually associated with molar pregnancy is associated with multiple theca lutein cysts due to ovarian hyperstimulation.